Thank you, Adam, for the introduction and for the invitation to speak today. So I'll talk both about the endovascular options for the management of erectile dysfunction, both arterial and venous. I have no disclosures. So erectile dysfunction is common. It affects 50% of men aged 40 to 70 years, and the prevalence increases with age. It's multifactorial, and establishing the underlying exact etiology can be challenging and definitely requires a multidisciplinary approach. And really other causes like psychological, neurogenic, hormonal and structural should be excluded before it comes to treating anything arterial or venous. Even cycling there has been some discourse as to whether cycling can, as an etiological factor in erectile dysfunction. But what I'm going to focus on today is arterial and venogenic erectile dysfunction. And what I will say is that these two cohorts are quite significantly different. Arterial disease tend to have the same risk factors as the cardiovascular risk factors and atherosclerotic diseases, patients with diabetes, obesity, hypertension, whereas they also tend to be older, whereas the venous disease patients tend to be a lot younger, usually with almost no comorbidities. The only most frequent comorbidity I think that I encounter with this cohort is anxiety, depression, which can obviously be a cause-effect conundrum. And it can be difficult to pinpoint venous as an etiology. I suppose positional component can be helpful and to suggest a venous leak. And then it comes to a good history and exam and imaging. So regarding imaging, it's essential really to diagnose the treatable vascular causes. Usually ultrasound is first line, a high quality CTA, and I would add that a CTA that needs to be read by a vascular specialist who knows what a treatable lesion is important for arterial disease, and then venography is gold standard for venogenic. I'll talk a little bit about our Doppler ultrasound because this is really important in the diagnosis of both, but particularly venous. We use a high-frequency linear probe. It's important to provide a calm and quiet atmosphere, assess for structural abnormalities, and then we assess both cavernosal arteries, a PSV of less than 10 at baseline or a difference of greater than 10 centimetres per second in PSV, suggestive of arterial dysfunction. Then we do an intracavernosal injection under ultrasound guidance of alprostadil, and serial Doppler exams at 5-minute intervals until the max PSV on the minimal EDV are achieved, usually about 20 minutes. And these are the parameters that we use. The main ones are PSV greater than 30 is considered normal, and an end diastolic velocity of greater than 5 in the presence of a normal arterial PSV is considered diagnostic of veno-occlusive dysfunction. And again, this is an example of a template report that we use, just recording everything at the 5-minute intervals, and patients are given post-procedural instruction sheet. So looking very specifically at arterial dysfunction, as I said, the pathogenesis is really for the vast majority of patients the same as all-cause atherosclerosis, multifactorial. This in turn causes smooth muscle atrophy and fibrosis and leads to impaired relaxation. There are going to be some causes of single lesion distal disease, whether this is the same atherosclerosis or a different etiological factor, I'm not sure. I've certainly come across some patients who've had trauma and have a single distal lesion that's treatable, but that's not the majority of patients. Wang and colleagues have done a lot of work in this area, and this is from a paper in 2020. What I think this really nicely shows, he's divided the pelvic arterial anatomy into zones, but what it nicely shows is that from distally, the pudendal vessels onwards, zone 4 and 5 here, the vessels are really small, so 2 millimeters or less. And as we know, particularly in diabetics, these are the patients that are most affected. So there has been a number of patients looking at this with variable follow-up, to be honest. Some of the earlier papers really treated the large vessels and have very poor clinical follow-up. Wang, again, has reported clinical success as defined by an improvement in the IIEF of 4, which is, I think, a reasonable endpoint in up to 74% of patients. When we look a little more closely at his data from 2016, there was 150 patients selected. A little under 45 patients had distal obstructive lesions. 22 patients completed follow-up. And these are the kind of lesions that are being treated. So you see the pre-procedural CTA, and you can see how subtle these lesions can be and why you really do need someone who's actually going to treat the patient to look at it. And this was the correlate on angio and follow-up post-angioplasty. This is a reasonably isolated, high-grade stenosis that has responded nicely. And Wang categorized his cohort into 3 groups of responders, I suppose, those with a sustained clinical response, which was 11 patients, initial success and then decline, 6 patients, and no response, only 5 patients. So I think, and apparently post-treatment PSV was the most significant factor in sustained clinical response. So I think there's certainly a lot of work to be done in this area. The treatment is promising, but establishing the cohort of patients that will actually benefit for this is going to be the main challenge. Is it those with predominantly hypertension? Or is it those with prior trauma? The jury's still really out on quite a bit of that. So moving on to venous dysfunction, the pathogenesis of veno-occlusive disease is much less established, and there are likely several mechanisms at play. As I said, it can be even more difficult to diagnose clearly than arterial. It's a diagnosis of exclusion. At our institution, all of our patients have have a Doppler ultrasound and are seen by referred to the interventional outpatient clinic. Veno-occlusive dysfunction can be treated with open surgical ligation or by pelvic vein embolization. There's literature describing both. A 2019 paper by Doppler included 8 cohort studies with 212 patients, and they found that endovascular therapy appears to be a safer alternative management than surgical management, with a success rate of 60%. And other more recent authors have even improved on that of their clinical success. However, again, published data is limited, with small numbers, heterogeneous data, and inconsistent endpoints. We have had good results locally with our technique, but the literature remains sparse, and we're currently recruiting at the Alfred for a prospective randomised trial for patients with venogenic ED. They're randomised to either sham or embolization procedure, and our endpoints are clinical success as defined by an improvement in the IIF of 4 points, and end-diastolic velocity improvement on ultrasound. Our crossover is allowed at 6 months, and our sample size was based on the 2019 analysis. And then inclusion and exclusion are fairly simple, really, again, based on Doppler ultrasound and the IIF. So patients are referred by a urologist with special interest. They're then sent to IR and the research team. They undergo Doppler ultrasound and come in for a cavernosogram. This is either confirmatory of ED or a screen fail. And they're randomised then to a sham procedure or treatment. So I'll just go through a few of our cases. I have a few videos, hopefully they'll play. This is a standard cavernosogram, so we'd do cavernosal injection under ultrasound, inject alprostadil and then contrast injection. And you can see a very extensive venous filling very rapidly here within a few seconds of injecting. This is in comparison, I'll just show you, this is a patient with no leak, and it's very unusual for us to get these patients with no leak because of the workup pre-procedure. But you can see that this is the same amount of time as the previous patient, and as you can see, there's almost no venous filling. So this is a negative study, but you can see that there's quite a marked difference generally when you're doing these exams. It's quite apparent when there is a leak and when there's not. When we confirm a leak, as in these cases here, we go ahead with embolization. Usually the larger draining veins are coil embolized. So their larger draining veins here are coil embolized, and that's to prevent reflux or non-target embolization into the iliac system. And then we use glue to embolize the smaller venous plexus. And this is a post-procedural angiogram here, so you can see after the embolization there's very little venous outflow. So there's a number of different access options. You can access from the right IJ, advance the sheath, as we did here, down to the pelvic veins and embolize from there. You can do a direct puncture, or you can access femoral vein here. And you can use either a number of different embolics. We have used, in this case, this is a sclerosant case. We have moved a little bit further away actually from using sclerosant as when it recurs, and sometimes they can recur a number of months or years later. Treatment after treatment, initial treatment with sclerosant can be quite challenging. So we tend to use coils and glue, and as I said, in this case, coils to exclude the iliac system, and then glue to treat the smaller vessels. If it's not possible to access from above, and some people prefer this as an initial approach, you can do a direct puncture of the dorsal penile vein, as we've done here, and coil and glue it directly through that. There's a small bit of residual on the right here that we came back and embolized from above. And lastly, the last option for embolization is a direct prostatic venous puncture, which is rare to have to do, but on occasion it's necessary. You can just about make out the needle here, going directly into the prostatic venous plexus, and embolization was performed then directly through that with glue. And the post-angiogram here demonstrates good embolization with very little filling at the end. So I suppose our initial results are promising. We're recruiting well into the study, and there has been improvement in our patients' IAEF and reduced EDV on ultrasound. But as I said, we're waiting. We'll hopefully have some preliminary results coming out soon. And to conclude, I think that we really do have a role here as interventional radiologists. We can certainly improve the quality of life for a lot of these patients. You know, some of these patients were younger patients trying to have families, and it really does have a significant impact treating these diseases. Having said that, patient selection for both arterial and venous etiologies is challenging, and probably the key to establishing this as a treatment. And certainly more work needs to be done here. We're not going to be doing CTAs on 50% of the 40 to 70-year-old population. So referring, having a urologist with a special interest referring appropriately is the first step in that. That's it. Thanks very much.
Thank you very much. That is extremely interesting, and it's great you're doing an RCT on this to see if it actually does work. What kind of complications and side effects do you see to these treatments?
Yeah, so the complications are actually fairly low. Obviously, non-target embolization is one of the ones that you'd be concerned about, but the rate of PE is certainly in our hands less than 1%, in the published literature probably less than 2%. The other things that you have to be aware of are, particularly when you're accessing through the dorsal penile vein, is that glue hardens and you can feel it, so you don't want to embolize too distally because that's very, obviously could be uncomfortable for the patients. So they're the two main ones that you want to avoid, non-target and distal embolization. But they're quite rare. It's actually a very straightforward procedure.